Okay, so thank you for that. So thank you for the introduction. As was mentioned, Dr. Alex Louie is my fellowship supervisor. So we'll be talking today about some of the current challenges in lung SBRT, as well as some exciting future opportunities. I have no disclosures. On today's agenda, we will first, because we've got a bit of a mixed cohort here in terms of specialties, we'll go through what exactly is SBRT, what the existing utility is in early stage non-small cell lung cancer, some areas of uncertainties where we are working hard to improve the outcomes, facing some of the failures we've had in lung SBRT, and then looking at lung SBRT in the context of metastatic and oligometastatic non-small cell lung cancer, and then looking at the future. So what is SBRT, aside from some fancy diagrams? SBRT stands for stereotactic body radiation therapy. You may have also heard the term SABR thrown around, which is short for stereotactic ablative radiotherapy. Tomato, tomato, they're effectively the same thing. And in simple terms, what it means is that we deliver 1, 2, 3, 4, 5 high-dose treatments of external beam radiation. Some physicians would consider it up to 8 or 10. We can't seem to agree on that. But ultimately, compared to conventional radiation, where we give small doses of radiation over an extended period of time, this is larger doses in a condensed time frame. In order to do this safely, we do it with high precision. So we use rigorous immobilization, precise treatment planning, careful motion evaluation, especially in the lung, where breathing can create movement in the tumors and the normal structures, and then modulate our treatment very carefully. This enables us to use quite small margins, meaning expansions beyond the actual tumor, to ensure that the tumor is covered. And this means that less normal tissue receives this super high dose of radiation. So this has become increasingly common over the last 15 or so years in both primary cancers, prostate, lung, CNS, as well as in the metastatic setting. In particular with lung, early stage non-small cell lung cancer is quite commonly treated with curative intent. And then metastatic non-small cell lung cancer, we'll talk about the myriad of options and indications there. So some of the SBRT hallmarks that I touched on, we account for motion through a 4D CT. The beams are often delivered from multiple angles, if not in a continuous arc. We often check with a cone beam CT on a daily basis to ensure we're treating the right area and the patients and tumor positioning are in the same area. This again enables us to use small tumor volumes, achieve very steep dose gradients. So we have a high dose followed by a very sharp fall off towards the low dose gradient, and are able to deliver a high dose per fraction with this. So as I'll go through a couple of things I mentioned here. So in terms of immobilization, a couple examples on the slide here. The top one is a thermoplastic shell, which immobilizes the neck, shoulders, and head, occasionally used when we're treating upper lung lesions. And below that, we see a young man who's about to undergo a CT simulation, but he's got this device pressing into his abdomen, which we call abdominal compression, which limits the amount of breathing that can be done, which reduces the motion of the tumor. Oh, this unfortunately does not appear to be working, but this should show the motion of the lung throughout the breathing cycle that we track routinely during our simulations in order to plan the radiation, so that we can carefully evaluate where the tumor is going in the normal tissues. And then every day on treatment, we do a quick scan comparing the patient's current anatomy and tumor position to what was planned on, and we're able to test for differences and ensure that the delivery continues to be safe and effective. So to get into a bit of the utility in early stage non-small cell lung cancer. Non-small cell lung cancer exists on a spectrum, or rather the patients, I suppose, exist on a spectrum of medically inoperable to perfectly fit and otherwise well. And so for fit patients, I think it's not controversial to say that surgery remains the gold standard of treatment. Unsurprisingly, in this population, there are a large number of patients with extensive comorbidities. And so SBRT really got its start in the medically inoperable grouping continues to be sort of the workhorse there. The definition of medically inoperable varies slightly, but ultimately we're looking at compromised lung function with FEV1 of less than 40% predicted, DLCO of less than 40% predicted, and things like pulmonary hypertension or needing supplemental oxygen at baseline. Patients can be medically inoperable for other reasons, including cardiac risks, blood thinners, and other comorbidities as well. These both the lung function and the other comorbidities exist on a spectrum. But luckily for us, SBRT is non-invasive, doesn't require any anesthetic, and has quite a limited toxicity profile in most cases. And this, for those who aren't familiar, the more common side effects are fatigue, which is usually self-limiting, some lung fibrosis, which is usually not clinically significant, some mild skin irritation, which will pass, and so loss of hair in the treated region, not systemically. Less likely, patients can develop pain, pneumonitis, dyspnea, or fever, again, which are often self-limiting. And then much more rare are the sort of severe side effects, major hemoptysis, fistula, spinal cord damage. And these have gotten much less common as our experience with the technique and technology has improved. So as I said, lung SBRT is quite common in the medically inoperable population. And there's a multitude of evidence to support that, starting with the single arm prospective trial, the RTOG 0236, which showed that it was both safe and effective treatment in this population. More recently, there's been some randomized evidence, phase 2 and phase 3 studies, comparing it to conventional radiation, which show some benefits. And then a host of retrospective evidence, as the field had been doing this for quite some time. As such, it's been a guideline supported standard of care in this population for going on 10 years. Not as much evidence exists in the borderline operable population. This is mainly propensity match retrospective evidence showing, I would say closer than expected outcomes to the surgical population when you are able to match the patients appropriately. And I think in this population, it's important that individual patient and physician assessment is required. So the ASTRO guidelines suggest that SBRT is a very good option when the perioperative mortality risk is in the range of 1 to 2%. And obviously shared decision-making rules the day here. In the medically operable population, there have been some studies looking at operable patients in attempts to randomize those operable patients to either surgery or SBRT. These have failed to accrue to date. There are a number of others ongoing that I'll touch on in a minute. Again, propensity matching studies show similar lung cancer specific survival in this population, although this data is hypothesis generating at best. And so perhaps somewhat controversially, we could be considering shared decision making in this population as well. To really drive home the differences between conventional and stereotactic radiation, in early stage non-small cell lung cancer, on the right here in the blue is the conventional 60 gray and 30 fractions that would have been standard 15 years ago in early stage population, compared to SBRT, a commonly used fractionation for peripheral lesions, like the one we see in the top corner here, 48 gray and 4 fractions. So the total dose of radiation when we deliver 60 gray and 30 fractions is a real 60 gray, as we call it, 60 units of radiation. Even though with the SBRT treatment, we're delivering less total units, 48, because we're delivering so much at one time in high doses, the equivalent effect it has on the tissue is actually much higher. So we're looking beyond 100 gray. Treatment time is much shorter in the SBRT group. The resources and time to plan have become much closer. They're quite similar now, which is another, as we've gained experience and improvements in our technology, and the radiation therapists and dosimetrists have become more familiar with the technique. And then we'll talk about outcomes. There have been studies comparing these head to head. So when we look at comparing SBRT with conventional radiation, both of which can be used to treat early stage lung cancers in a curative fashion, For many years, there was this was being stereotactic body radiation was being done off trial at many centers. It was the standard. Finally, an Australian multi-institutional study was done, phase 3, about 100 patients, randomizing patients between conventional radiation and SBRT, which showed improvements in local control, statistically better overall survival with the SBRT group, and no major differences in toxicity between the groups. Overall, it was quite well tolerated. So this really was good validation for what, for better or worse, was already being done across the world quite commonly. Because of these successes and the demonstrated safety and efficacy, the question was raised, well, could we be doing as well as the surgical population? Is this similar to lobectomy or even sublobar resection? And as I mentioned before, a number of trials were attempted. None have accrued successfully. There was 2 small trials totaling about 60 patients, that the STARS and Roselle trial, that had a pooled analysis done, which quite provocatively showed statistically better 3-year overall survival in the SABRE group, this SBRT group, driven largely by some early deaths in the surgical group. Additionally, there were fewer grade 3 toxicities in the SABRE population and no deaths. However, this needs to be interpreted with a great degree of caution, given that this was an unplanned pooled analysis of 2 failed trials, and there have been a lot of editorials written about this paper. And hopefully, hopefully I haven't convinced you one way or another with this. There are luckily for us, there are a number of ongoing randomized control trials comparing surgery and SABRE. So there's the VA system in the US, Veterans Affairs System, has the VALOR trial, which is attempting to enroll 670 patients, comparing stereotactic radiation versus surgery, looking at overall survival in early stage lung cancer patients. It is currently accruing. There's also the US based stablemates trial, which is using an interesting design where patients are given the choice of which option they would prefer before they're actually entered into the trial, surgery or radiation. And then if their choice matches where they are randomized to, they are then put on the trial. Targeting 272 patients, comparing SBRT versus sublobar resection, looking at 3-year overall survival in a high-risk operable patient. So this is sort of the borderline operable patient we talked about before, and expecting to be completed accrual in 2024. And then there's a Chinese randomized phase 2 trial, smaller number of patients, looking at 2-year local regional control in small tumors in medically operable patients. So we'll await the results of those trials. So overall, I've made SBRT sound quite good. So, why aren't we using it for everything? What's the catch here? So these high unfractionated doses that we give to the tumor can also mean high doses to normal tissues. And in turn, sometimes patient or tumor factors can make it tricky to deliver safely. As we mentioned before, tumors in patients can move. The patients are often unwell. Sometimes the lesions are too large to be able to deliver these high doses safely, or in a bad position. Sometimes they're actually too small for us to reliably track during our treatments. And the presence of multiple lesions can add some complication. There are some patients that it's potentially dangerous in, and we should pay careful attention. So these are patients with interstitial lung disease, patients where the tumor is quite close to the mediastinum. And then the treatment is not perfect. Sometimes we fail either locally, regionally, or distantly, and we can walk through some mitigating factors of that. So there are a number of areas of uncertainty in our current treatment that we're actively investigating and are on the top of mind of many radiation oncologists in the field. So these are some known high-risk scenarios that that keep us up at night, I would say. Interstitial lung disease is a big one. This is a very challenging population. The presence of interstitial lung disease seems to be a risk factor for developing concurrent cancer. So 10 to 25% of the population develops a non-small cell lung cancer during their lifetime. They often have poor lung function or concurrent illnesses that preclude them from being surgical candidates. And the option of not treating these people is also not great. It's untreated early stage non-small cell lung cancer, median survival is quite short. Problematically, there are very high rates of serious toxicity with SBRT. So systematic review and meta-analysis showed treatment-related mortality of on the order of 15%, with quite high rates of grade 3 plus toxicity. So you might say, well, why not use something else? Well, then, unfortunately, other systemic and local treatments offer, often quite high risks of severe toxicity as well. So very challenging patient population that I know we're all familiar with. So how do we optimize these patients? So first, I think it's important to confirm the diagnosis, high resolution CT, referral to respirology for expert assessment, and then potentially radiology and MDT review. Important to note that the subtype and degree of the interstitial lung disease is likely important in the potential magnitude of the radiation toxicity if treatment is done. Important for us to rely on our colleagues. So as I mentioned, respirology assessment for first diagnosis and then potential optimization. Our colleagues in interventional radiology, radio frequency ablation can sometimes offer a better alternative. It's been shown to have slightly less toxicity in some retrospective series, but the risk is still substantial. Medical oncology opinion, and then available clinical trials. I think in this population, it's important to know when to say no or listen to when the patient's telling you no. So I think considering competing risks, so ILD gap score, which is a useful prognostic tool that can, based on the patient's comorbidities and lung function, can give you a sense of their overall prognosis and performance status. Lesion location, growth rate, and symptom burden are important. Is this a lesion that's likely to cause trouble in the next 6 to 8 months, or is it something we can watch for a period of time? And then, of course, listening to the patient, understanding their preferences, their risk tolerance, their general wellness. So when radiation is indicated or required, what's the right dose? How do we treat these people safely? We still don't know that. But given the high risks, dose and volume compromises are likely warranted. And there's some retrospective evidence to suggest that keeping your volume of the lung receiving less, or receiving 20 gray or more, less than 6.5%, and your mean lung dose below 4.5 may correlate to lower treatment mortality. And then obviously informed consent if you are going ahead with treatment. We are awaiting the results of the Aspire ILD trial, which was a single-arm dose-finding study led by a group in London. They accrued 39 patients with early-stage non-small cell lung cancer with concurrent diagnosis of interstitial lung disease who were not fit for surgery, looking at overall survival. And the way this study was designed was that patients in the first wave were treated with 50 gray and 5 fractions and observed for a period of time. There was a plan to de-escalate with any grade 5 toxicity or treatment-related deaths within 6 months of treatment, down to as low as 45 gray and 15 fractions, which is effectively a palliative dose. We probably aren't curing people with that. The accrual has completed, and the results are awaited at ASTRO 2023, which will hopefully give us at least a little more confidence when we do feel it's appropriate to treat these patients. We'll have a little more information about dose and safety. A few other scenarios that the data is quite limited on, but we encounter not infrequently. So patients who have had previous treatment, either with 60 gray and 30 fractions for a larger advanced lung cancer or previous stereotactic who have failed locally. If the patient is not fit for an operation as salvage, this retreatment with curative intent doses of radiation is technically feasible. The series that are published have grade 3 plus toxicity rates that are very low, but I think should be taken with a large grain of salt, given how small they are and how few they are. And I think careful attention to high-risk OIRs, organs at risk, such as the airways, major vessels, and chest wall are important in this population. And there's an example of one of the series that showed reasonable outcomes. Multiple primaries. So sometimes we encounter patients who have 2, 3, or 4 synchronous lung cancers. And there has been some work done here with Dr. Chung's team looking at patients who received either multiple lesions treated at once or over the relatively short period of time in sequence that showed clinically significant risk of pneumonitis, the risk of clinically significant pneumonitis was quite low, less than 10% at 1 year, indicating that this is safe when planned appropriately. Additionally, occasionally we see patients that are post-extensive surgery on the contralateral side, either multiple lobes or post-pneumonectomy. The evidence here as well is not very good, but a pooled analysis of about 50 or 60 patients that had stereotactic treatment on the residual lung showed a reasonable pooled toxicity rate of 13%. And so this is an area of active investigation, gets our heart rate up, but does appear to be reasonable to consider. Some areas that we have been learning quite a lot about that previously caused us some trouble, what we'll call the no-fly zone. So this is dating back to some of the earlier days of SBRT, where there was clearly increased toxicity, including a number of treatment deaths related to tumors that were central or ultracentral, aka close to the major airways or blood vessels in the middle of the chest. A large prospective study did demonstrate that those in the central location had significantly higher rate of toxicity, 11 times higher, in fact, and there were several deaths. And this was coined as, or this zone, I guess, where the risk was higher was earned the name the no-fly zone, as in we're not supposed to fly there with our radiation. As such, there have been a number of investigations trying to investigate how we can fly in this area a little more safely. So here, the green dot representing a central lesion, so within this 2 centimeter outline of the proximal bronchial tree. Other studies have defined this as within 2 centimeters of any mediastinal structure, including the heart, esophagus, or major vessels. And then you have the ultracentral lesion here in green, which definition varies by study again, but in general, your high dose radiation volume overlaps with the proximal bronchial tree, esophagus, or pulmonary artery and vein. There was a single-arm dose escalation study on central lung cancers published in 2019 by Dr. Bajak, who works at Princess Margaret. This found substantial toxicity across a number of dose levels, including 7% dose limiting toxicity at the top end dose level, which was 60 gray in 5 fractions, which has given people some pause. It is important to note that none of the tested levels, none of the tested doses, including doses that we use somewhat commonly here, were completely safe, as there was grade 5 toxicities in all groups. And relatively few of these tumors were ultracentral, so we're looking at primarily central lesions here. For what it's worth, the local control rate and overall survival were respectable in the study. Evidence in ultracentral is more scarce. These lesions are less common or are handled surgically more commonly. There are a number of studies, retrospective series showing quite high rates of radiation-related deaths, up to here nearing 25%. Of note, a dose we use commonly here, 50 and 5. There is retrospective evidence showing limited toxicity as well as limited treatment-related death. So this prompts the question, how do we fly in a no-fly zone, especially with suboptimal data to help guide our decision-making? And so really the best way we know how is dose adjustments. And so quite commonly we use lower doses than we would use in other parts of the lung when we're in the central or ultracentral region. 50 and 5 or 60 and 15 are slightly more gentle and used commonly here. A systematic review looked at a number of ultracentral lesions to help us beyond just dose reduction, considering patient factors that put people at higher risk for treatment-related mortality. And what we found was previous use of bevacizumab or anticoagulants, both of which would put you at higher risk of bleeds, bronchial tree invasion of the tumor, which can regress and leave a fistula following the radiation, and highest dose to the actual airway were all predictive for treatment mortality. And so considering these things in patient and treatment factors are helpful in guiding our decision-making. We are awaiting the results of SUNSET, which is a Capri Canadian Pulmonary Radiotherapy Investigators Group, collaborative group trial that is, again, a dose-finding study for ultracentral non-small cell lung cancers, looking at doses ranging from 60 and 15 up to 60 and 5. The accrual is completed and we're expecting the results at ASTRO this year. There are a number of things, as I mentioned, the radiation therapy isn't perfect in this population. There are failures and we are seeking to improve on those failures. So the common patterns of failure, we have a lesion in the right lung here, zap it with some radiation. You can have a local failure. This occurs roughly 5 to 15% of the time at 3 years, depending on the series or the trial you're looking at. There are regional failures, which occur less commonly, 3 to 10% of the time. And then distant failures, which are slightly more common again at 3 years. So looking at our local failures, why are we failing locally? Is it because we're not being accurate and or precise enough? Is it because we're not giving enough dose to kill all the tumor cells? Is it that some of the cells within these tumors are inherently radio-resistant and not susceptible to our treatment? Or are there other reasons? I don't have good answers for you, but I can help, or we can walk through some data that may provide some ideas on this. So one of the more interesting, quite small studies that's come out in the last few years is a study called Mutsaers, which looked at treating patients with high-dose stereotactic radiation to small cancers, non-small cell lung cancers, as a neoadjuvant approach to surgery. So these patients all had high-dose radiation and then 10 weeks later underwent surgical resection, either with lobectomy or segmentectomy as planned. So they were all operative candidates. The combination treatment was well tolerated with no surgical deaths. The most interesting or surprising finding was that the pathologic complete response rate in the trial was 60%. So one way of looking at it would be to say that it's higher than any neoadjuvant therapy to date and very promising. Another way to look at it would be that it's much lower than expected, given that we often will quote a local control rate of 90% at 2 to 3 years for our high-dose radiation alone. There was also a surprisingly large number of nodal relapses in this series. So this raises a couple questions. Does the lack of pathologic complete response mean failure, or does it mean that perhaps the cells had been induced into a quiescent state that may not recur or are not able to divide? Or is it that not enough time had passed for the radiation damage to have fully manifested? And these are things that we don't have the answers for. And then the second question, which is a topic of ongoing study, is there a broader benefit to preoperative SBRT, right? Will these patients end up doing better than expected with surgery alone? One of the challenges we deal with in identifying local failures is that the radiation causes fibrosis in the lung, which can evolve and change over time. So here on the left of the screen, we see the lesion in the right lung. Shortly after radiation therapy, you can see some evolving change there. There's no discrete lesion. And then at 12 months, there's sort of a consolidation again, sort of in the area where the lesion was. And the question is always, quite a common clinical question is this recurrence, or is this just post-radiation fibrosis? And at present, we use multidisciplinary assessment, serial CTs with a number of criteria. PET scan can be helpful, repeat biopsy if they're fit, surgical resection. Going forward, artificial intelligence and radiomics. This is a common topic of study and may prove helpful, which we'll touch on more. Is it possible we're failing because we're not giving enough radiation dose to the tumor? There are a wide variety of doses and fractionations that would be used to treat a tumor that can be found as representative as the one on the middle of the chart here. Quite commonly at Sunnybrook, we would use 48 gray in 4 fractions, which equates to a biologic tumor dose of about 106 gray. Other centers may use something like 54 gray in 3 fractions, which is higher, approaching 150. Sometimes we would use 34 gray in 1 fraction, which is approaching 150 again. And there's a variety of other doses that would be deemed acceptable. The bottom line is we don't know. We don't know what the right dose is, and we don't know if more is better. This is complicated further by the fact that you can prescribe the treatment differently. You can prescribe it so the whole tumor is getting roughly the same dose, or that the center of the tumor is getting a much hotter dose than the rest of the tumor. There are other factors like tumor size, type of tumor, histology, and the tumor microenvironment, things like hypoxia, which we know have an impact on the ability of radiation to kill cancer. And increases in dose may improve control, but they also will likely increase the risk of toxicities. So there are multiple retrospective analysis which shows that a BED10, or basically the biologic effect of the radiation, the equivalent effect of the radiation of more than 100 gray leads to better tumor control than those less than 100 gray. The question remains, is there another threshold well beyond this level? If our current technology with photon treatment, which is what's commonly used with stereotactic body radiation in Canada, cannot deliver higher doses, then can we try other particle types? Is that a possibility? So there are other particles that are used in radiation therapy around the world that have some unique properties that enable you to potentially deliver more dose to the tumor with less dose to the normal tissue. So you may have heard the terms protons or carbon ions or helium, a number under investigation. They're very limited access globally. These facilities are extremely expensive to build and upkeep, and we don't have any access in Canada yet. There's limited data, despite the conceptual benefits, to support benefit. So on the bottom here, we've got a sample proton cartoon, which, as you see, the lighter teal color is spreading less and I guess this is a liver, maybe lower lung or liver case. The SBRT, and then compare it again to conventional radiation. So, and this is a carbon ion plan, as you can see on the left, more of the brighter colors washing into the posterior aspect of the lung through the spinal cord, much more conformal with the carbon ions. But again, no good data to support the fact that this is clinically meaningful. More recently, there is an announcement that potentially there will be a proton facility built in Canada, but whether or not lung cancers are on the list of things to be treated remains to be seen. And just briefly, there are a number of ongoing ways we can improve both our targeting of the tumor, our mapping of the tumor, and our delivery of the radiation. So there's always technology gains happening in the treatment planning software and our actual linear accelerators, our ability to track patients' motion and to deliver beams from multiple angles in order to give more dose without compromising the normal tissue. And improved understanding over time, as we gain more knowledge and experience of this, may enable us to tease out some of the dose and volume effects that will help with toxicity mitigation or improve our control of the tumors. Some of the distant failures, regional or distant failures. So SBRT is inherently a local treatment. It's not designed to treat the lymph nodes in addition to the primary in most situations. So the failures in either lymph nodes or more distantly are a result of either pre-existing micrometastatic disease or incompletely controlled primary. Given how commonly we see distant failures, 15 to 20% of the time, the question is raised about effective and tolerable adjuvant systemic therapy needed. So if these patients were to undergo surgery, many of them would qualify for cytotoxic chemotherapy in the adjuvant setting. And NCCN mimics this with the SBRT population. However, this is more challenging given many of them are inoperable and medically frail for other reasons. So there are a number of studies looking at the role of adjuvant, neoadjuvant, and concurrent targeted therapies or immunotherapies in this space, which may help reduce those failures. And this is an exciting and emerging opportunity. We're seeing more and more targetable mutations. This is a slide borrowed from a 2022 paper, which suggests that more than 60% of the Western population with non-small cell lung cancer with adenocarcinoma will present with a targetable mutation, which is certainly much higher than it used to be, as evidenced by this slide demonstrating sort of 2011 on the far left to 2021 on the right. You can just see the pace of all these new drugs that offer potential clinical benefit to our patients. The question is whether or not they can be offered or they would benefit following stereotactic radiation and whether it's safe. So a study that's opening here is the Pacific 4 study. It's a randomized phase 3 trial, double-blinded, target accrual of 690 patients looking at stereotactic radiation to early stage non-small cell lung cancer with 24 months of durvalumab adjuvantly versus 24 months of placebo adjuvantly. And there are sub-studies in this study, including a single-arm sub-study for TKI-eligible patients, including EGFR positive. And there are a number of other trials looking at nivolumab and pembrolizumab that are accruing elsewhere as well. So this is a hot topic at the moment. And as seen here, there are a number of ongoing studies. So we've touched on early stage lung cancer. SBRT and oligo or metastatic non-small cell lung cancer is another very hot topic. So as most on the video chat are familiar with, metastatic disease exists as a spectrum. It's on the left, we have oligometastasis, generally defined as less than 5 total lesions. Moving to the far right, we have more widely metastatic disease. And the question is, where is the optimal role for radiation for each of these patients, if any? So there's quite a detailed taxonomy of this oligo categorization. We all are using different terms to describe these patients. And so there was in 2020 in Lancet Oncology, there's a European-led consensus in an attempt to standardize some of the terminology. And again, the question is, where can SBRT be helpful and how can we help? Is it in an overall survival way? Is it in a progression-free survival way? Is it to improve symptoms? I think there's evidence to support all of these in non-small cell lung cancer. So the sort of landmark trial was the Gomez trial, which was published in 2016, which randomized patients with less than 3 non-small cell lung cancer metastases who had not progressed on first-line systemic therapy, and then went on to be randomized between SBRT to all lesions as a consolidative approach, versus maintenance, drug, or observation. And the study was actually closed quite early, as on interim analysis, there was quite a profound progression-free survival benefit found with the local consolidative therapy. As you see here, median PFS 14.2 months versus 4.4 months, and median OS was also significantly improved. This has led to a study similar design, but a phase 3 style, phase 2/3 study this time, LU002, targeting 400 patients, again, less than 3 mets, de novo or metastatic stage 4 non-small cell lung cancer, with no contraindications to treatment. Same design. This trial is currently accruing well, but is paused for interim monitoring, so we await the preliminary results from this. In the oligo progression setting, so patients who are perhaps polymetastatic or oligometastatic and have a single lesion growing while on systemic therapy or off systemic therapy, there is a randomized trial looking at lung cancer patients in this space. So the CURB trial was a phase 2 randomized control trial looking at 106 patients, 59 of whom had non-small cell lung cancer, less than 5 oligoprogressive lesions after at least 1 line of systemic therapy. And the patients were randomized to either standard of care versus standard of care and SBRT to all progressing sites, looking at progression-free survival. This study also was closed at interim analysis for clear benefit, which showed median progression-free survival of 3.2 months in the standard arm and 7.2 in the SBRT arm, which was significant, low rates of toxicity and no difference in quality of life between arms. On subgroup analysis, the patients with lung cancer actually showed a much more profound benefit. So 2.2 months versus 10 months, and actually no benefit in the breast group, which is provocative, but does support the use of this approach in oligoprogressive lung cancer patients. In polymetastatic patients or oligometastatic patients who are very symptomatic from their lesions, the question is, can SBRT offer benefit over conventional radiation for symptom management? And this is the topic of Dr. Segal's SC24 trial, randomized phase 2/3 study, which included 51 non-small cell lung cancer patients with symptomatic vertebral metastases, comparing conventional palliative radiation versus higher dose radiation to the spinal nets, looking at feasibility and complete pain response at 3 months. And in fact, this was a positive trial. It did show a substantially better complete pain response with stereotactic radiation, which is quite novel, not an explored topic in the past. This benefit persisted at 6 months, and the group showed similar toxicity and quality of life profiles. So this leads us to think that maybe SBRT can induce a better symptom response, which may apply to other tumor areas around the body, and or it may provide more durable control of lesions in sensitive or high-risk regions. SBRT for intracranial disease. So I'm sure many of you remember the era where a single brain met would buy you whole brain radiation if you weren't fit for a surgery. This has evolved over time to stereotactic radiation, to single brain metastasis, to multiple brain metastasis, and now really envelope pushing work here at Sunnybrook that's showing treatment of up to 50 lesions in the brain with the goal of sparing the neurocognitive toxicity that can come with whole brain radiation therapy. There are a couple of randomized studies really pushing the boundaries of metastasis-directed therapy, or SBRT. There's the Sabre Comet 10 trial that's being run by Dr. Palma in London. It's a phase 3 trial comparing Sabre to all sites of disease for patients with 4 to 10 sites of disease, targeting 159 patients, with looking at overall survival. This is extension of the previous work that showed a significant benefit in the patients with 1 to 3 metastatic disease, and a number of non-small cell lung cancer patients will be on this trial. And then if we're really pushing the boundaries of metastasis-directed therapy, there's a phase 1 feasibility and dose escalation trial also happening with that group, showing or treating up to 50 metastases in patients who are otherwise ineligible for further drug therapy or declining the therapy. And again, this is a dose escalation study. So in the bottom corner here, we see an example of what the radiation plan looks like, and it's quite boundary pushing. We'll see what the results show. Okay, how much time do I have? Okay, a few minutes. So where to next? So artificial intelligence is staking its claim in the medical world, and lung cancer is not immune from this. There are a few areas of active investigation that artificial intelligence can be helpful with. First is in diagnosis, both of diagnosing lung cancers, but also diagnosing subsequent problems related to radiation treatment. So there are studies ongoing looking at whether we can use radiomics, so data from the CT scans, to determine which subtype of lung cancer a patient has without a biopsy. Again, to help us demystify the recurrence versus fibrosis. There's a lot of work going on there. And then actually downtown, they're using artificial intelligence on their cone beam CTs, their planning CTs, to screen for interstitial lung disease, which is interesting work. Additionally, there is planning efficiencies that can be gained from artificial intelligence, so they can help with volume delineation, as well as quality assurance work, which should hopefully make our jobs, make us better at our jobs and make us more efficient at our jobs, but not completely take away my job. That would be ideal. And obviously there's a role for big data, artificial intelligence, gathering and parsing data in order to help us answer the numerous questions that I've raised during this talk. Finally, I'm planning on using ChatGPT to help write a number of my papers going forward. The abscopal effect is an ongoing area of investigation. Just briefly, this is the concept of when you radiate one metastatic lesion and you get a spray of tumor antigens, which prime the immune system to cause a response in unirradiated or otherwise uninvolved metastatic lesions. So the story has shown promise in mice models, as well as in conjunction with immunotherapy and a secondary effort to prime the immune system. However, the results in humans have been less promising. So there have been a couple of randomized studies looking at SBRT plus immunotherapy to a single lesion and monitoring the residual lesions versus just SBRT or just immunotherapy alone, and neither of these have managed to show clinically or statistically significant benefit. And there are a number of phase 3 trials investigating dose timing and sequencing that are ongoing. As I mentioned, SBRT and immunotherapy together in some format is a hot topic, as you can see from all of these active accruing studies. One of the obvious questions is this safe? Is it safe to be giving SBRT at the same time or just before or just after immunotherapy? And that's a question we don't yet know. There are reports of overlapping and potentially serious synergistic toxicity, pneumonitis, hemorrhage, etc. Data is very limited. Most of it's retrospective. But as these prospective trials continue to accrue, we will get more data. The question for the radiation oncologist is always, what is the appropriate washout period? How long do you want the drug held before or after? That's currently unknown. Most drugs appear safe to be given within close temporal proximity to the radiation, with several exceptions. Notably, VEGF inhibitors have a number of major bleed cases, like bevacizumab. At this time, MDT opinion and monitoring of ongoing trials remains very important. This is based on quite a recent ESTRO-led, European-led guideline, consensus guideline, about how long radiation should be held, or sorry, how long the drug should be held before high dose radiation is given in the metastatic setting. And if you can just bear with me briefly, that the stratification of colors is basically the disagreement in the group about whether we're holding for a short period of time, not holding at all, or holding for an extended period of time. And as you can see, there's really limited consensus amongst the group. So in conclusion, SBRT is safe and effective treatment for many patients with early stage non-small cell lung cancer, as well as metastatic non-small cell lung cancer. In the early stage setting, we've got ongoing work to improve our ability to treat patients in high-risk scenarios like ILD and ultracentral tumors. There's continuing work to optimize the technique, and the role of adjuvant therapy with targeted therapy is under investigation. In the metastatic setting, it does appear that non-small cell lung cancer patients appear to benefit from aggressive oligometastatic and oligoprogressive management. And the optimal interaction, timing, and safety of the systemic therapy remains under investigation. And we will continue to work to improve our ability to deliver treatment safely. I'll take questions, comments, rebuttals from surgeons.
Thank you, Adam. That was an excellent overview. My apologies to Alex. I thought Patrick was your supervisor. I should have had Alex